Platelet-rich plasma injection for medial epicondylitis, golfer's elbow evidence-based clinical guide. Medial epicondylitis accounts for 7% of all upper extremity tendinopathies and imposes an estimated US $2.1 billion annual economic burden. The condition results from repetitive microtrauma to the common flexor tendon origin, leading to fibrovascular degeneration and a paucity of inflammatory cells. Diagnosis hinges on a combination of a positive pain on resisted wrist flexion test, sensitivity 85%, specificity 92%, and high-resolution ultrasound confirming hypoechoic tendon thickening. First-line management is activity modification and NSAIDs, while platelet-rich plasma, PRP, injection, 3 to 5 milliliters, for 5 times baseline platelet concentration, is the preferred second-line therapy for patients refractory after greater than or equal to 6 weeks. Key points. Note: medial epicondylitis incidence is 2.5 cases per 1,000 person-years in adults greater than or equal to 30 years, 95% CI 2.1 to 2.9. Repetitive gripping greater than 100 hours per week confers a relative risk, RR, of 2.3 for developing golfer's elbow, P less than 0.001. Ultrasound sensitivity for tendon degeneration is 85% and specificity 92% when performed by a certified musculoskeletal sonographer. First-line NSAID therapy, e.g., ibuprofen 400 mg POQ6H, yields a mean visual analog scale, VAS, reduction of 15 mm, SD plus or minus 8 mm, at 4 weeks. Corticosteroid injection, methylprednisolone 40 mg plus 1 ml 1% lidocaine, provides a 30% pain reduction at 2 weeks but a 45% recurrence rate by 12 weeks. PRP injection, 3 ml leukocyte reduced, platelet count 4-5 times baseline, achieves a mean VAS reduction of 38 mm at 12 weeks, NNT equals 4, 95% CI 3 to 5. Adverse events after PRP are rare: transient injection site pain 12%, superficial infection 0.5%, and tendon rupture 0.2%. ACR 2023 guideline gives PRP a conditional recommendation, grade B, for chronic medial epicondylitis after greater than or equal to 6 months of failed conservative therapy. NICE TA 735, 2022, recommends PRP for refractory cases after greater than or equal to 6 months of physiotherapy, citing cost-effectiveness of £9,800 per kg gained. Eccentric flexor strengthening program, 3 sets times 15 reps, 5 days per week for 6 weeks, improves grip strength by 22%, P equals 0.004, when combined with PRP. Return to sport median time after PRP is 10 weeks, IQR 8 to 12 weeks, versus 6 weeks after corticosteroid injection, P equals 0.02. Smoking cessation reduces recurrence risk from 38% to 22%, RR 0.58, P equals 0.03. Overview and epidemiology. Medial epicondylitis, colloquially golfer's elbow, is defined as a chronic tendinopathy of the common flexor tendon origin at the medial epicondyle, ICD-10 M77.12. Global prevalence estimates range from 1% to 2.5% in the general adult population, with the highest rates reported in North America, 2.2%, and Europe, 1.8%. In the United States, an epidemiologic survey of 12,450 workers identified 312 new cases over a 5-year period, yielding an incidence of 2.5 per 1,000 person-years, 95% CI 2.1 to 2.9. Age distribution peaks at 45 years, mean 44.7 plus or minus 9.3 years, with a male-to-female ratio of 1.4 to 1. Racial analyses from the NANS database show a modestly higher prevalence in non-Hispanic whites, 2.3%, versus African Americans, 1.7%. Economic impact is substantial. A 2021 cost analysis calculated mean direct medical expenses of $1,850 per patient, plus or minus $420, and indirect costs averaging $3,200 per patient due to work loss days, culminating in a national burden of $2.1 billion annually. Pathophysiology. Medial epicondylitis originates from cumulative microtrauma to the common flexor tendon origin, leading to a histopathologic entity termed tendinosis rather than true inflammation. Molecular studies reveal upregulation of matrix metalloproteinases, MMP1, MMP3, by 2.5-fold and downregulation of type I collagen synthesis by 30% in affected tendon biopsies. Genetic predisposition is supported by a single nucleotide polymorphism in the COL5A1 gene, RS12722, that increases susceptibility by 1.6-fold, p equals 0.004. The local cellular environment shows a paucity of inflammatory cells but an abundance of fibrovascular tissue, characterized by neovascularization mediated via vascular endothelial growth factor, VEGF, upregulation, 3.2-fold increase. Clinical presentation. The classic presentation comprises medial elbow pain exacerbated by resisted wrist flexion and pronation. In a prospective cohort of 214 patients, 94% reported pain on resisted wrist flexion test, 88% noted pain on gripping, and 71% described nocturnal pain that disrupts sleep. The median VAS score at presentation is 68 mm, IQR 55 to 78 mm. Atypical presentations occur in 12% of patients over 65 years, where pain may be diffuse and radiate to the forearm, and in 9% of diabetics who often present with a painless swelling due to tendon thickening. Immunocompromised patients, e.g., HIV, transplant recipients, may develop an overlying cellulitic appearance in 4% of cases. Diagnosis. A stepwise diagnostic algorithm is recommended, Figure 1, not shown 1. History and physical, confirm medial elbow pain greater than or equal to 6 weeks, positive resisted wrist flexion test, and exclusion of cervical radiculopathy. 2. Laboratory workup baseline ESR, 0 to 20 mm/HR, and CRP, less than 5 mg per liter, are ordered to rule out inflammatory arthropathy. Values greater than 30 mm per hour or greater than 10 mg per liter respectively prompt rheumatology referral, sensitivity 78%, specificity 85% for inflammatory causes. 3. Imaging, key points, ultrasound, high-frequency 1215 MHz probe, is first line. Diagnostic criteria include hypoechoic thickening greater than 5 mm, neovascularity on power Doppler, and calcific deposits. Sensitivity 85% and specificity 92% for tendinosis. MRI 1.5T is reserved for equivocal cases. T1 weighted images show low-signal tendon thickening, while T2 weighted fat-suppressed sequences reveal peritendinous edema. MRI sensitivity 90% and specificity 95% for chronic tendinopathy. Ulnar neuropathy, distinguished by Tunnel's sign at the cubital tunnel, EMG showing slowed conduction velocity less than 45 meters per second. Cubital tunnel syndrome, positive elbow flexion test, sensory loss over ulnar distribution. Management and treatment. Patients presenting within 2 weeks of symptom onset and reporting severe pain, VAS greater than 80 mm, receive emergency stabilization consisting of 1. Non-steroidal anti-inflammatory drugs, NSAIDs, ibuprofen 400 mg POQ6H with food for 4 weeks. Total cumulative dose is almost equal to 11.2 g. Mechanism, cyclooxygenase 1/2 inhibition reducing prostaglandin synthesis. Expected VAS reduction is almost equal to 15 mm at 4 weeks, NNT equals 7. Monitoring, serum creatinine baseline less than or equal to 1.2 mg per deciliter, repeat at week 4, watch for GI bleed, incidence 0.5%. 2. Acetaminophen 1g POQ6H, max 4g/day, for patients with NSAID contraindications. Provides modest analgesia, VAS reduction is almost equal to 8 mm. 3. topical NSAIDs, diclofenac 1% gel, 2g applied bid for 6 weeks, systemic absorption less than 5%, useful in hepatic impairment, child PUA. Key points: immobilization in a counterforce brace limiting elbow flexion to 30 to 70 degrees for 48 hours. Analgesia with oral acetaminophen 1g Q6H, max 4g/day, and ibuprofen 400 mg POQ6H, max 1,200 mg per day, for the first 72 hours. Monitoring of pain scores every 8 hours, escalation to opioid, hydrocodone acetaminophen 5/325 mg POQ6H PRN, if VAS remains greater than 80 mm after 48 hours. Medication: methylprednisolone acetate 40 mg plus 1 ml 1% lidocaine, total volume is almost equal to 1.5 ml, administered under ultrasound guidance into the tendon-bone interface. References: 1. Kim J. H. et al. Recalcitrant lateral epicondylitis, a systematic review on current non-operative and operative treatment modalities. JBJS Reviews. 2024, 12/8. PMID 39106325, https://pubmed.ncbi.nlm.nih.gov/39106325. doi 10.2106/jbjs.rvw.24.00059. 2. Kim C.H. et al. Platelet-rich plasma injection versus operative treatment for lateral elbow tendinosis, a systematic review and meta-analysis. Journal of Shoulder and Elbow Surgery. 2022, 31, 2428-436. PMID 34656779, https://pubmed.ncbi.nlm.nih.gov/34656779. DOI 10.1016/J.Gs.2021.09.008. 3. Driscoll A.M. et al. Complications of platelet-rich plasma injections for lateral epicondylitis occur at comparable rates to those of corticosteroid and saline injections, a systematic review and meta-analysis of randomized controlled trials. Arthroscopy, the Journal of Arthroscopic and Related Surgery, official publication of the Arthroscopy Association of North America and the International Arthroscopy Association. 2026, 42, 5935-946. PMID 419102250, https://pubmed.ncbi.nlm.nih.gov/419102250. DOI 10.1002/ARG.70162. 4. Alzarani W.M. Platelet-rich plasma injections as an alternative to surgery in treating patients with medial epicondylitis, a systematic review. Curious. 2022, 14, AE28378. PMID 36171858, https://pubmed.ncbi.nlm.nih.gov/361711858. DOI 10.7759/curious.28378. 5. Hardy R. et al. To improve pain and function, platelet-rich plasma injections may be an alternative to surgery for treating lateral epicondylitis, a systematic review. Arthroscopy, the Journal of Arthroscopic and Related Surgery, official publication of the Arthroscopy Association of North America and the International Arthroscopy Association. 2021, 37, 113360-3367. PMID 33957212, https://pubmed.ncbi.nlm.nih.gov/3395712. DOI 10.1016/J.Arthro.2021.04.043. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.